David, show yourself. I demand it.
Agreed. What's the restaurant you like here, Dr. Krupata? They're hiring, FYI. Friendly's is hiring, just so you know.
Well,
Okay.
I'm on my way.
I was going to say that's where we're all going to end up. Like, after I give this talk, at least I'll be working at Friendly's from now on. Well,
Is that how we're finally going to get rid of you?
it's a potential option, let's just say.
I'm going to just wait for like 2 more minutes, make sure like we got everyone, like we'll start at 8:05. Okay. And in the meantime, just housekeeping rules, just try to mute yourself so that you don't disturb the speaker and any echoing sounds. And also if you have any questions, please type in the chat box. Before we used to do QA panel, but now we can see your questions in the chat box, so we can ask the speakers at the end, okay? So we have welcome everybody. We have a great line of speakers tonight at the QC Core Insights. First, it's my pleasure to introduce Dr. Ajita Prabhu. She'll be talking about retromuscular, like barrier-coated meshes versus non-coated mesh in retromuscular plane. So one of the QC proceeds from Cleveland Clinic, and Ajita can take away.
Okay, thanks so much for having me. As Prashanth mentioned, we are going to be talking about non-coated versus barrier-coated mesh in the retrorectus position. And see if I can get my slide to advance. Is it advancing for you? Here we go.
Yes.
Here are my disclosures, which are not relevant. They're all robotic disclosures. And our work here is really focused on open cases. And before I get too far into it, I'd also like to give credit to Jonah Thomas, who is a rising intern in general surgery. He did a couple of years of research with us. He's from the Lerner College of Medicine here at Cleveland Clinic and is going to be starting at MGH in July. So thank you for sharing your slides and your work with us, Jonah, and I'll be presenting it today. So one of the things that I think is really special about this is that we have the ability to kind of look full way at the work that we're doing, and we look at some of the details of what we do in the operating room and the technical aspects of it, and looking at each other's shared data gives us the opportunity to really kind of drill down and decide whether the practices that we are all doing are similar to each other, and if not, what the differences are and why. So this talk is about anti-adhesive barriers that, as we know, are intended to prevent or reduce adhesions. And they're typically used in an intraperitoneal position to prevent the viscera from sticking to a mesh device at the time of a hernia operation. At some point, we were looking at QC data for other reasons, and we noted that there was a higher than expected placement of coated mesh in the retrorectus position. And so we had some curiosity about that and thought that, some of the properties of barrier coated meshes, specifically that they are meant not to adhere to the surrounding tissues, may or may not make them undesirable in a retrorectus position and could contribute possibly to wound morbidity. So that's what this work is around. And our study aimed to compare the wound morbidity in patients who had non-coated mesh placed in the retrorectus position versus patients who had barrier-coated mesh placed in the same position. And by the way, this work was submitted to and accepted to the Hernia Journal and was published in May. So specifically for study outcomes, we focused on 30-day wound morbidity rates, including SSIs, SSOs, and surgical site occurrences requiring procedural intervention. We also looked at hernia recurrence and hernia-related quality of life scores. So initially, and throughout the study, the inclusion criteria were elective class 1 hernias. They were open ventral hernia repair with retrorectus mesh and with 30-day follow-up completed. Also, we excluded mesh in all other positions, all other wound classes, and then repairs of non-incisional hernias or infection or minimally invasive repairs. And then as far as the propensity matched analysis, we performed this based on a number of factors that we thought could contribute potentially to wound morbidity. So I won't read them all out here, but they're the usual players. And so this is essentially our consort diagram, if you would. And in the beginning, we started out with 23,300 patients meeting inclusion criteria. But then when we went through and excluded the patients that didn't meet all of our criteria for inclusion, we ended up with 3,600 cases meeting inclusion criteria. There were almost 3,300 in the non-coded mesh group, and then there were 330 almost in the coded mesh group. Once we did a propensity match, it essentially ended up being 2-to-1, non-coded versus coded mesh. And you can see here in this whisker plot that towards the right is the pre-matched standardized mean differences. And then if you look at the blue line after our propensity score matching, you can see that the groups came much more closely together with many of their operative details and characteristics. So this table is a little bit busy, and they all are. They're not necessarily meant to be read, but these are basically the patient demographics after we did our propensity score match. And what you can see is that, as I mentioned, there are almost 650 non-coded patients and 320 coded patients. And if you look at their demographics and characteristics, they all came to be the same or similar groups. As far as operative details go, after propensity score matching, the groups also looked very similar. The one thing that I'd like to point out a little bit, though, is that in the coded mesh group, there was a higher proportion of external oblique release, which we know can potentially contribute to wound morbidity itself due to large subcutaneous flats. So after propensity score matching, here are our outcomes. And so as I mentioned, our primary outcomes were wound events. And you can see that the group that received coded mesh in the retrorectus position or retromuscular position ended up with a higher incidence of SSOs and also SSOs requiring procedural intervention. And those both reached statistical significance. And you can see in the box below that, as I have highlighted, that the main driver of that was seromas. So as with every study, there are some limitations. This is a retrospective study, and we can't really speak to the selection bias in terms of potential mesh choice specifically. So I'm sure that many of us have spoken with surgeons who sometimes when they're unable to completely get the posterior rectus sheath closed, they might place a barrier-coated mesh in that position to protect from having bowel stick to their closure if it's a tenuous closure. So that's one of the things that we're unable to account for. The other thing is that, as I mentioned, there were probably more external oblique component separations in the coded mesh group than the non-coded mesh group. And it's not clear what the contribution of that is towards wound morbidity that we saw. And then finally, in terms of being able to identify the location of the seroma, this is not something that we collect in the QC. So it's hard to say specifically whether the barrier coating itself drove the seromas and where those were located. However, we can say at least that there was a correlation of greater wound morbidity and definitely greater wound morbidity that required intervention. And also, those patients that had a surgical site occurrence with procedural intervention had a tendency, it didn't reach statistical significance, but to have a reoperation. None of these patients had their meshes resected, and ultimately, they did well overall. And I don't know what happened to my quality of life slide. Let me just see if I have that. Okay, so the last thing I forgot to mention at the bottom here is that as far as our quality of life went in both groups, it was similar to both groups. And then we looked also at hernia recurrence with a composite score out to 3 years follow-up, which obviously was a very low percentage. The highest percentage of follow-up was 1 year, but recurrence was not noted to be different between the groups. So that is it. And our conclusion based on this work is that, first of all, there's a greater incidence of surgical site occurrence requiring procedural intervention when barrier-coated mesh is placed in the retrorectus position for an open case. We know that barrier-coated mesh is more costly than bare mesh. And based on those findings and the concerning risk for increasing surgical site occurrence requiring procedural intervention, our conclusion was that barrier-coated mesh is not justified for use in the retrorectus space. And that's all I have.
Great, thanks so much, Ajita. One question we had from the chat is, can you tell us again the absolute difference in the surgical site occurrences and those that required procedural intervention between the two groups? And if you think that's enough evidence to overall recommend avoiding putting coated mesh in the retrorectus space.
Can you repeat the first part of that question?
Yeah, the question was to just basically this part showing us the absolute difference between the SSOs and the SSOPIs that you have highlighted. And then whether you think this is enough evidence to recommend against coated mesh in the retrorectus space.
That's a good question. And I think that's something that we really kind of have to think about critically. So first of all, you can see the absolute difference between SSOs in number is not that much. And as you mentioned, it did reach statistical significance despite being a small absolute difference between the two. And similarly, the difference between the groups in terms of SSOPIs, the absolute difference was really only 4 patients. And that also did reach statistical significance. So what we can say is that, you know, these are fairly decent numbers of patients in both groups. And while we're not able to really comment on catastrophic outcomes associated with these findings, I do think it is concerning that these patients had a higher incidence of procedural intervention. And we don't really know, if you kind of look at the bottom there, you can see that our long-term follow-up is lacking in these patients. So the question is, what is the clinical consequence of these occurrences and these surgical site occurrences requiring procedural intervention? That part, I think, in our lives has remained to be answered. I don't think that there's a clear answer to that as of yet. However, I would say all of those wound morbidity issues that we're seeing, there is at least an association. And so that, given that finding, as well as the increased cost of these barrier-coated meshes, I think it at the very least gives me pause. I don't think that we can say categorically should or should not be used in such a strong way. However, it is hard to make an argument if you know that there may be an increased chance of having to go back and do a procedure to these patients to then persist in using that. And the other thing I'll say, last thing I'll say, and then I'll let you go, but you know, we don't fully understand if the complexity of these cases is what drove these surgeons to place a barrier-coated mesh into that position. And I don't think from this work we can fully identify that, because that may be a selection bias issue, as I mentioned before. So we don't know that the case is technically harder. One thing we did look at, though, was operative time greater than 2 hours. We know that was similar, and we know, generally speaking, as far as the hernias themselves, they were similar, at least with regard to width and possibly complexity too. But we can't ever fully make a categorical statement like that.
Yeah, and kind of as an extension of that, another question we had was, why would a surgeon ever use a barrier mesh in the retrorectus space? You mentioned if there's tension on closure of the posterior sheath would be one reason. Any other reasons you've identified why those might be used, especially given the cost differences since the barrier meshes are more expensive?
I mean, I think there's tension as one issue, but another issue that I've seen discussed in various forums is when there are holes in the posterior rectus sheath, and the posterior rectus sheath is thought to be thin. I think the concern is that, you know, that a bare mesh in that position could certainly adhere to the small intestine or large intestine. And or obviously there's a potential of getting an internal hernia or intraprosthetic between the prosthetic and the peritoneum type of hernia. So, you know, that's not been my personal practice to place a barrier-coated mesh into that position, but that is the context in which I've heard that discussed. But if anybody else has any other reasons that they've heard, I'd certainly be interested to hear them.
Well, I mean, maybe, can I just tag a little bit to that? Because I think, and again, I think Ajita's conclusions with this data are accurate, and it's hard to conclude because we're missing some stuff. But at the end of the day, the people on this call are the people putting in the data. So I think it's worth like a quick conversation. And maybe like I'd start off with a very aggressive statement, which would be, I don't think there's ever a reason to put a barrier coated mesh in the retrorectus or preperitoneal space. I think that kind of answers George's questions. I think though, we see it a fair amount, and honestly, we see it a lot in our redo TARs where something went wrong. And I think a lot of that is because all those things about there being tension on the posterior sheath, there being holes in the peritoneum, all of those need to be addressed with other measures and not with a change of mesh choice. And so I think it's kind of it's more of a sign to me, at least, and this data doesn't prove it because we can't, but maybe other people have a different opinion on the call, but it's a sign that you're doing a difficult case. You're having trouble with the peritoneum. If the peritoneum is tight, you need to do other moves like go further lateral, extend your TAR dissection to actually get the peritoneum to close easier, plug these holes with omentum, use a piece of absorbable mesh in some way. But the move is not to use a barrier coated mesh for the reasons that Ajita said. So, I think there's, and the final thing I'll just say is, I think that really this study puts the final nail in the coffin of whether you should use it, because the onus is on the barrier coated mesh. Rana, as you said, it costs a lot more money. So it has to actually be measurably better. And if anything, there's signals that it's actually worse. So I think this kind of shows that it really shouldn't be doing it. There's clearly no advantage. And it's more technical things to fix that.
Yeah, great. And then one final question before moving on to Dr. Pierce's, are people seeing severe adhesions with barrier coated meshes on reoperation after IPOM hernia repair? I am not. I mean, I think it depends on the type of mesh, but I don't think the issue here is the adhesions. I think it's more the barrier coating that's causing the seromas in the retrorectus space. But as an IPOM, I haven't seen issues with severe adhesions. I don't know what your thoughts are, Ajita, but.
I mean, I have removed a barrier coated mesh from the lumen of the bowel before, so I think it's hard to, but I do think that there are things we don't fully understand or appreciate about the behavior of the barrier coating in the abdomen. We can say by and large, they're safe within the abdomen, which I think, and we've all heard the conversation over the past year or two that, perhaps barrier coated mesh, perhaps mesh should be kept outside of the abdomen. I think that's kind of a big discussion. And, I'm not gonna lie, I'm pretty sure there's a recorded talk of me somewhere saying that we should put mesh where it goes, which is outside of the peritoneal cavity. I'm pretty sure you can find that on the internet somewhere. But that said, I would just say we don't fully have the ability to predict how each patient is going to react to each one of these barrier coatings. And even though that there is some preclinical work, some animal related work, I don't think in humans we have enough information to say that. We can say by and large, the incidence of mesh related complication is relatively low, including for intraperitoneal meshes.
Okay, great. Thank you. That was a great discussion. Next, we'll have Dr. Richard Pierce he's the director of Vanderbilt University Hernia Center in Nashville, Tennessee. He's going to be talking to us about outcomes of light and midweight synthetic mesh repair in CDC class 2 and 3 wounds.
There we go. I'm unmuted. Let's see. Can everybody see these slides? Hopefully. Slides up. All right, great. All right. Thanks so much for having me, guys. I'm going to try to move quickly through the first part of the talk as an introduction. We'll move along then. So we've been looking at some use of permanent prosthetic mesh in atypical situations. So basically, as I'm sure everybody's pretty aware, there are no mesh products that are currently FDA approved for use in contaminated scenarios. And therefore, in these scenarios, people are still often using either biologically derived meshes or synthetic absorbable meshes. As you're probably also aware, biologic mesh prosthetics are extremely expensive and may lack durability. And although the synthetic absorbable meshes might be a little bit cheaper, those are also suffer from the possibility of having higher recurrence rates and problems there. Therefore, it was our hypothesis that if we were able to find certain permanent mesh prosthetics, namely light or midweight macroporous polypropylene meshes that could be safe in contaminated scenarios, they might offer a good alternative to biologics or biosynthetics. So we therefore, Monica Pulse, one of our star residents here, did a pilot study here at Vanderbilt where we wanted to determine the incidence of wound complication recurrence rates after an open peristomal hernia repair. This was an onlay type procedure. And we wanted to see if how our outcomes compared with those, as these represented class 3 wounds. So therefore, she did a retrospective identification of patients from between January of 2015 through March 2020. And then we looked at our incidence of surgical site infection, surgical site occurrence, and hernia recurrence as well. Overall, we had a total of 52 patients. With you can see these are their demographics here, mean age of 59, mostly white patients. We didn't have a particularly long follow-up at the time we did this study. This was presented as a poster at the AHS last year. One of our other residents, Paul Brosnahan, has been working on updating the data so we can have a little more follow-up. But you can see we had about a 10% SSI rate, a 2% SSO rate, 24% recurrence rate, which is probably about on par for peristomals, and that our time to recurrence was around 7 months. As I said, we had 52 patients identified, 2 were excluded due to lack of follow-up. Any of the SSIs that were there were resolved with antibiotics. And I think the most important point that we found, though, is that we had no incidence of requiring to remove mesh for infection, even though often ostomies were pulled directly up through this lightweight mesh. There were a couple early recurrences that required operation, but again, we're dealing with peristomals. So after doing this and being encouraged by this data, we wanted to look at a bigger set of patients and look at things in a slightly different way. So therefore, we undertook, these are our conclusions, that we thought it might be that macroporous might represent a viable alternative to mesh and a good cost-effective alternative as well. So as I was saying, we want to look at this in a bigger patient population. So therefore, we turned to the QC, and we had to modify our study a little bit and look slightly at things slightly differently. But our goal here was to compare the incidence of 30 and 90-day SSOs and SSIs, and compare the use of the lightweight macroporous mesh in either class 1 wounds or class 2 and 3 wounds. We did not want to do class 4 wounds, as they were pretty, we felt they were probably a little too dirty, and maybe that was pushing the envelope a little too much. So our hypothesis is that we thought the SSIs and SSOs would be similar, or there'd be no observable difference at 90 days. And then we also wanted to look at mesh infection, mesh removal, and hernia recurrence at 1 year. So this shows our algorithm, and most of this data is actually pretty hot off the press. We've just generated it in the past couple of weeks through the excellent work of Molly Olson. So we started off with 57,000 patients. We excluded patients who had an inguinal hernia or op notes were not entered. Anybody that did not get an incisional hernia, as these were ventral incisional hernias we were looking at. We excluded all class 4 wounds, dropped out those that did not get mesh, and then also dropped out those that got a heavyweight mesh or did not have a synthetic component. So we ended up with a study population of about 13,000 patients. And sorry, I didn't show it clearly here, but approximately 12,000 of those were class 1 wounds, and another 1,000 roughly were fell into the cohort of class 2 and 3 wounds. So our methods were to do a univariate analysis, and we then used a logistic regression to compare the 2 patient cohorts to control for multiple factors here, which you see: age, BMI, hernia size, medical comorbidities, and concomitant procedures, which were all actually quite important. So the tables are a little detailed, but I've tried to highlight the important points. This is basically looking at the patient demographics, and you see that they're similar in age, race, gender distribution, and even BMI. Although when we look at their ASA class, we see that the patients tend to be a little bit sicker in the class 2 and 3 group, named 68 versus 53%, whereas there's more ASA class 2 patients in the class 1. There were some minor differences in medical comorbidities, but I think the most important ones are highlighted down here in the bottom, and these all reach statistical significance. Namely, the class 2 and 3 wounds were more likely to have open abdomens, have had a prior component separation. Obviously, as might be expected, they had a history of abdominal wall SSI, many of which actually had what were considered a currently active infection, and they certainly had higher rates of prior mesh infection. such that the patients looked like, then what happened during their operations? Most of the cases were elective, but we also see here that the operative times tend to be longer in the class 2 and class 3 groups. The larger categories are falling out up here versus the class 1. Significantly higher rate of intraoperative complications as might be expected. And those complications were generally due to things like bowel injury, bladder injury, and enough blood loss to require a transfusion. And almost all of those came out to showing statistical significance. Likewise, concomitant procedures performed were a strong predictor of a class 2 or 3 wound or closely associated with it. And these included colorectal procedures, foregut procedures, small bowel, urologic, gynecologic. So as it might be expected, they were probably a contributor to that wound class. I highlighted this next one just because I thought it was interesting that actually we saw that 45% roughly of patients are still getting preoperative chlorhexidine scrubs at home, which I thought was interesting, especially given the publications that have come out of the QC showing that chlorhexidine scrubs might actually be detrimental to hernia patients. So just an interesting observation. We see that most of about twice as many percentage-wise patients in the class 2 and 3 group got epidurals for pain control. And we also see down here that the hernia width and length were larger in the class 2 and 3 groups. Obviously, there was a higher rate of prior mesh excision, which again may have contributed to the wound class of the case. There was more complete or partial excision in the class 2 or 3, whereas often there was no excision in the class 1 groups. Also note that the class 2 and 3 tended to be much more heavily skewed towards an open approach, whereas laparoscopic and robotic cases were generally falling into the class 1 category. Some subcutaneous flaps raise was slightly higher, but not really, I don't know if that's clinically significant. This will be the last long table, sorry. Again, as we saw, the class 2 and 3 wounds tended to have larger defects and therefore reflected in larger mesh sizes. And here we're seeing that mostly bare permanent synthetic mesh was being used in the class 2 and 3 wounds compared to the class 1, whereas the class 1 had more barrier composite meshes used compared to the class 2 and 3. There's actually a higher rate of myofascial release in the class 2 and 3, almost 79% versus 50%. And that was mostly due to, I didn't show all of them here, mostly due to the use of tar at a higher rate in class 2 and 3 versus class 1. Interestingly, although I don't think it's clinically significant, there was a slightly higher fascial closure rate in the class 2 and 3. Obviously, drains were used almost twice as often. And also interestingly is that over 99% of patients actually had the wound closed in both groups. So there wasn't a huge amount of people that were being left with open wounds in class 2 and 3 scenarios. This actually shows our real outcomes of interest. As you see here, probably going against our hopeful hypothesis, basically 30-day SSIs and SSOs, excluding infections, as well as SSOPIs, they're all higher at 30 and 90 days. The mesh removal rates at 1 year, and these numbers, just to note, are actually quite a bit lower given the 1 year follow-up. But it's higher in the class 2 and 3 group. The mesh infection rate's higher, although they're not particularly high in the clinical scenario. And at least for the numbers we have, we see that the hernia recurrence rate in both groups is roughly the same, given the data that we have. And then lastly, when we actually do the multivariate regression analysis to adjust for comorbidities, this shows the odds ratios of class 2, 3 versus class 1. So it still holds that SSOPIs at 90 and 30 days are still higher in the class 2 and 3 groups. The SSIs in these groups are also significantly higher, whereas the SSOs that exclude the infections either are roughly similar or at least did not reach statistical significance. And similarly, the clinical recurrence at 1 year did not reach statistical significance despite the center of this bar, but that's probably somewhat reflective of rather small numbers. So in conclusion, we felt that relative to those performed in a sterile field, contaminated wounds tend to be seen in more comorbid patients, are associated with larger defects, are accompanied by concomitant procedures, and generally represent more complex cases. In terms of outcomes, we did see that the contaminated scenarios result in higher rates of SSIs and SSOPIs, although within our adjusted analysis, there was no detectable difference on SSO rates. Mesh infection and mesh removal rates are also increased in these non-sterile settings, although overall they're still relatively infrequent. And from what we've seen, at least in 1 year, we could not detect the difference in ventral hernia recurrence rates between clean and contaminated wounds. Lastly, I'm sorry, I also forgot to throw in a disclosure slide, so I'll mention that here real quick. My only disclosure is that I do receive some research funding from Intuitive Surgical Solutions. It has nothing to do with this study whatsoever. I want to thank our excellent team of residents, Monica, Joe, and Paul here at Vanderbilt, my fellow colleagues, Trey, Joe, Meredith, Alex Hawkins, Ricky Schnall are all attendings. Jose Diaz runs our animal lab, and Joan Kaiser is a research nurse. We have 3 fantastic undergrads, Sammy Rose and Isabella Schaefer and AJ Bethurham, who are doing work with us. And of course, Molly and Aileen with the ACHQC team, and Ben Paulus, who actually laid the groundwork for a lot of this work when he was still here at Vanderbilt. So I'll wrap that up.
That's great, Rich. I have a question for you. You mentioned the higher rate of mesh removal and mesh infection, and it seemed, at least from the tables, that there was inordinately a high amount of synthetic mesh used in class 2 and 3 wounds. Do you think that could have contributed to the fact that there was more mesh removal, or what do you think was the main contributing factor why there was such a big difference? Do you think it was the CDC class alone, or what do you think were the other main contributing factors to that? It just looked like there were a lot more of that permanent mesh used in the of the non-barrier coated in the class 2 and 3.
I think it's just the fact that that's where, that's what we wanted to really look at and see was, if we're using this permanent mesh in a contaminated scenario, does it have to come out all the time? Again, sorry, I'm looking dark in the shirt. In the study we did at Vanderbilt, where we looked back at our parastomal hernia repairs, and we put the mesh, and we did not have to remove that mesh at all. And I wanted to see if that was going to play out within the QC as well. And I think the numbers were not inordinately high in terms of mesh infection and mesh removal, but I think that I have to admit, as I looked over the data after this, when I think my original hypothesis that it might behave similarly, then we saw that there's more SSIs, more SSOs, more mesh infection. It was a little bit of a duh moment, to be quite honest. But
well, hey, Rich,
yeah.
Can I ask you a question? So I think this is kind of a classic example, and it is kind of played out to, what happens when you think something, you look at the data that involves, 100, 200, 300, whatever surgeons, a lot more patients, and all of a sudden you don't find what you were hoping to find, and kind of how do you cope with that? And so, to me, this data shows that there should be a significant pause in thinking that synthetic mesh is okay in these cases. You had a 3 times higher mesh removal rate. That's not insignificant. Every one of those is a big deal.
Yep.
So I guess, my question, and I wasn't exactly sure if I could glean this from your data, is were you able to figure out how much of this was related to just the fact that they were CDC class 2 and 3 wounds versus the fact that maybe it might be relevant as far as the synthetic mesh? You know what I'm asking? Could you figure that out or not really?
So I actually, I'll have to admit, Mike, that's a great question. Yeah, I've already been talking with Molly and some of my colleagues here that I think where this may lead is to actually a secondary study. And I'm not sure if we'll do a secondary, we may do it and roll it into this. Again, I never want to, Ben always warns against salami slicing, but I think what might be maybe a more interesting question to ask is, how do synthetic permanent meshes in a contaminated scenario compared to within the QC compared to biologics or absorbable synthetics in a similar situation. I think that'd be something really nice to determine.
So, I mean, can I just ask you real quick? So, I mean, you did this, you looked at this data. So what are you going to do tomorrow when you have a CDC class 3 wound? I mean, what are you going to tell the patient if you use synthetic mesh in this scenario? Like, how are you going to handle this data? Because this is yours. You set it up. Now you got it. You got to deal with it.
I tell all my patients that there is certainly a higher rate of that. I even tell them that there is no mesh that is approved for this use. However, I can also say that at least so far in my hands, I have not yet had to remove a mesh. Again, something else that we can't exactly get out of the QC on this is some of the more granular treatment effects. I'll be honest, when I do some of these open peristomal hernia repairs and I do this Veller-Chevrel onlay, I leave a drain in and I keep the patients on, if it's a ileostomy, I keep them on antibiotic coverage for enteric bacteria until that drain puts out 30 cc's a day or less for 2 days in a row. And then we pull the drain and stop their antibiotics. We don't obviously record a lot of antibiotic. We don't record any really antibiotic use other than initial antibiotic treatment in the QC. So that's not something that we could look at. The drain placement is recorded, and certainly the drains were higher use in the synthetic ones. But that's what I tell my patients. I said, you know what, I don't know if I'm just doing something a little differently, but I feel like I've had good luck with it and I have not had to take out any mesh yet.
Rich, like great talk. I have one question. Have you looked at evaluated the meshes which are removed? Is there any particular type of mesh which stands out in terms of when you remove the mesh?
So that's a really good question. And I know I haven't addressed this with Ben and Mike, but I asked Molly about it. And I was told that we are not allowed to look at or name individual meshes. And I don't know, you guys can correct me if you want, but that's what I was told. Because I said, well, Molly, let's look at which meshes were removed, which ones were infected, which ones came out. And I was kind of told that was a bit of a no-no. I don't know if Ben or Mike want to comment on that as you guys are.
Yeah, I mean, I think, we look at categories, not particularly by name. So obviously, I think you could look at heavyweight mesh, medium weight mesh, coated mesh. You could look at biologic mesh. I think at the end of the day, when you really kind of start to get to individual named meshes, there's a lot of opportunity for bias in the way the data is, difficulty analysis, having enough of a denominator. I think truthfully, there's just limitations to this data set that you have to be careful when you kind of look at that, both, quite frankly, when you find a positive finding and when you find a negative finding. So that's been our policy. And I think it still is a good one.
I think it's a great topic because I tend to use, even in the meshes which are infected, I remove from the intraperitoneally. Now I do repair on these meshes when I do an intracutaneous fistula. I end up using a synthetic mesh mostly only in that position. But my question is, I'm not interested in the company making it. I'm rather interested in is there polypropylene versus polyester, monofilament versus polyfilament.
We have the capability to do that type of thing. I think the flip side, we really kind of think about that type of thing when you really want to look like it's this interesting balance that if you want to look at the name of the mesh, then maybe we should look at the name of the surgeon and see if there's a difference of how many of the meshes come out, because we all know that a lot of this stuff has to do with surgeons, has nothing to do with the mesh.
Absolutely right.
I think the level of granularity of this data set, I think it has its limitations, and I think we have to kind of, I think that's always an important thing to manage, but just the level that we should look at.
And Ben wanted to make a quick comment about something before we move on.
Oh yeah, thanks, Rana. So one of the cool things about the QC is that we have a lot of different stakeholders that participate in the QC. Even here tonight, Core Insights. One of the people we have on is actually George Bailey from the FDA. He's one of the officers in the FDA and is actually part of the executive council of the QC. So George, I'm curious to see, and George is a surgeon. So, your thoughts on this discussion. I mean, this is all off-label stuff. I know we've discussed this at multiple different time points over the years. And I know you can't speak, officially for the FDA, but as a surgeon and also from a regulatory standpoint, what are your thoughts on this discussion? I mean, this is all, pretty aggressive use of permanent prosthetic mesh.
Well, thanks, Ben. Thanks for allowing me to express my thoughts here. I mean, I think off-label use is going to happen, depending on the surgical situation you're in. And I will say this, not that FDA encourages off-label use, but if that off-label use results in what we call real-world evidence that we can subsequently use for regulatory decisions, we encourage it. And so in terms of collecting that off-label use data in the registry, we will certainly look at it for future regulatory decisions, maybe expansions of indications of use of some of these meshes, for sure. So not that we encourage it, but this is an extremely interesting discussion. And when I was a resident, my attendings used to say, challenge dogma. And we see that almost every day in this business. And so, and sometimes that's good and sometimes it isn't so good. So collecting the data is important.
Okay, thanks, George. And I think it's important for everyone to know on this call, both the surgeons and entering data, and also we have a lot of industry reps here. The data really can go for that purpose, where if we find that for particular indications, say permanent synthetic mesh has a reasonable complication profile in class 2, class 3 wounds, which again wasn't answered by this study necessarily, but that information can go for an on-label indication for that particular type of product. So it's an important point that is something that the QC did.
Absolutely. Thanks, Ben.
I guess we'll take one last question. One of them asked, does this data suggest that we should stage class 2 and 3 cases whenever possible? Rich?
Because that's, to me, I'd probably say yes, if possible, and you can stage it and you can keep, make a wound that is going to be class 2, 3, or 4, and stage it and make it back to a class 1, where then you're going to feel more comfortable putting in mesh. I would certainly do that. And I do that quite frequently. Prashanth, you mentioned, the scenario of an EC fistula or something like that. I tell all my patients, this is going to be a staged operation. We're going to try to fix the problem as best we can, let you heal up for 6, 12 months, clear whatever infections there. And then if and when that hernia comes back, we'll come back and fix it in a more definitive way later on.
Okay. All right. Let's moving on. Thanks, Rich. It's a great talk and great discussion. All right. I'm going to introduce our next speaker. Dr. Flavio Malcher is one of my colleagues at Montefiore Medical Center, and he's going to talk about incisional hernia repair in transplant patients population.
You hear me now?
Yes, we can.
Okay. So just confirm that you have my full screen.
Yes, we do.
So thank you QC one more time for the opportunity to present this data. This all starts when I got here in Monte 3 years ago. I faced a very strong and organized transplant program. And on my ABWOL mind, I started wondering if we could dive a little bit deeper into this data of how those hernias are managed on the transplant population. So we published our first paper on our own data set on the incisional hernia repairs on transplant people. And I spoke with the QC, and we were allowed to dig in on the QC data on results and risk factors for surgical site occurrence infection and recurrence after incision hernia repair in abdominal transplant population. So that paper was published this year, and I'll try to share with you our main results. So those are my disclosure, but we're not talking about any specific mesh or anything related to those companies. The purpose of this study was to analyze, investigate the risk factors for recurrence, surgical site occurrence, infection, and after incision hernia repair, we're not discussing ingnos, following abdominal transplantation, mainly kidney, pancreas, and liver. Why we decided to do this? We all are taught that the incision hernia incision hernias are very common on transplant people, and everyone that works at tertiary center, as I do, we see a lot of those patients. It is estimated about 15 to 20% on kidney transplant and 35 in liver and pancreas. To be honest with you, when I discussed this data with our own transplant surgeons, they said, no, that's too high. We don't have that incidence. I mean, as always on general surgery, the surgeons, they don't think they have this amount of recurrence in our case as abdominal surgeons or incision hernia as general surgeons. And there's amazingly, there's not enough data or a lot of data out there specific to dive into that data set of patients or the different cohorts. So with that in mind, after we obtained consent, RB here in institution, we dig into the QC data. We went after patients under over 18 with incision or ventral hernia who has a prior solid organ transplant, and at least have 30 days follow-up completely on the database. So we start out of at that time almost 6,000 patients that were into the database, and we exclude a bunch of them, and we got 166 patients that met inclusion criteria. So with that results, we analyze a little bit deeper each of those outcomes. So out of those 166 patients, 2/3 were liver transplant and a third was a kidney transplant. Interestingly enough, out of that population, 17% has a prior history of abdominal surgical site infections prior. I'm not discussing the surgical site infection or after the hernia repair or prior surgery. 4 patients has intra-op complications. The 30 days outcomes, 8% was they were readmitted. 17 patients present some kind of complication that we analyzed, being 2 superficial surgical site infection, 10 seromas, 4 cellulitis, 3 with serous drainage from the wound, but they were not deep or organ space abscesses. Overall complication 26%, and 1 mortality. Mean length of stay of 4 days, and I was, to be honest, quite surprised how fast those patients came back home. And when we started analyzing recurrence, we have different incidents because we need to analyze as much patients we were able to extract in 30 days, 180 days, 1 year, and 2 years. So if we see early recurrence very low, 1%, 22% on 180 days, and 37% on 1 year and 29 at 2 years. So that's a limit analysis once you have only 7 patients that complete 2-year follow-up. But anyways, 2 out of those 7, they present a recurrence. The long-term composite recurrence was 28%. So 21 out of 75 patients that met criteria for long-term follow-up present any kind of recurrence. So just to give some baseline about follow-up, out of the almost 30,000 patients at that time in the database with the ventral hernia repair, only 32% of those had long-term follow-up, and so is interesting to see that it's not common as expected long-term follow-up, and 32% have follow-up our database here in incision hernia on transplant patient, we got 45% with long-term follow-up. So maybe the transplant patient are more followed than the general population is followed. And out of the recurrence rate on the ventral hernias on QC is about 16% versus the 28% that we have in the study. And as imagined, we have more recurrence on that population than the general population. And this is the general table of results. I just want to pinpoint what risk factors were statistically significant. BMI for SSO required intervention. Hypertension was for a 2-year follow-up recurrence rate. Diabetes was for surgical site occurrence requiring intervention as expected, and open abdominal history was very powerful when analyzing those surgical site occurrences. Interestingly enough, and for me was the what surprised me more was immune suppression was a negative predictor factor for surgical site infection or occurrence or recurring intervention. Something that, interestingly enough, happened with our own study on our, I think it was 107 patients of this institution, and they repeated on the QC findings. So immunosuppression seemed to protect on the early post-op for surgical site occurrences. And something that is not here is BMI was also associated with the 180-day recurrence rate that is not included on this table. Limitation of this study for sure is a small sample size, only 166 patients, extremely low follow-up rates and long term. And something that was very hard to analyze as well was that a third of the patient, they have already recurrent hernias. So, but it was not possible to analyze the first repair that led to the recurrence. We are only analyzing the recurrent incision hernia repair on the transplant population. So what we could extract from this analysis is BMI, as expected, BMI, diabetes, and open abdomen are associated with SSO requiring intervention. Hypertension is associated with hernia recurrence. And I said that is a negative correlation between immunosuppression status and surgical site occurrence requiring intervention. But only 81% of the cohort was actually into immunosuppression, but interestingly enough, it was a negative protective factor, let's put it this way. So in conclusion, it seems that the same risk factors that run in the general population for complications, they apply here, and definitely we need to keep studying this population to see if we can find something else different, but I still believe we need a special care for those patients when we are approaching those herniations. So that's all I got for you guys, and thank you so much for the opportunity again to present.
That was great, Flavio. One comment we had in the chat box was that given the high incidence of transplant hernias, you found only 160 in the QC. So do you think it's because we're not fixing these or because they're difficult? For example, people are commenting that after renal transplant, these are especially difficult hernias to fix. What do you, from your practice, what do you suppose is the reason why the numbers aren't as high as we would expect them to be in the QC?
I can think about a few factors. First of all, at least here in my institution, when I got here, there has this culture of the transplant surgeons. They want to fix everything that happens with their patients. That's so it was very common to the transplant surgeons, they address the hernias. So, and for sure, they are not inputting those patients on any QC, on any center from QC. Little by little, me and Prashanth, we are being able to try to put ourselves available for them, and we are seeing more and more of those patients. Secondly, maybe the amount of centers that are putting data in QC, the heavy users are not heavy transplant centers, and maybe the private practice guys, they are not in tertiary centers that have a lot of those patients in their daily practice. And as always, QC is a surgeon input database. We may see that some surgeons do not input or make complex cases, or they expect bad outcomes. I hope that is not really something that happens, but I can foresee that happening. But I was kind of surprised as well that only 166 patients is even fewer patients, or about the same number of patients that we have in our own cohort, because it's not hard to find those patients here. Once the transplant service, they have their own database, so it's easier to go after those patients. And most of those repairs are our own, are not done by me. They were done by the transplant surgeons.
Yeah, that's a great point. That's something we face at our institution as well, that the transplant surgeons are fixing a lot of the hernias themselves. Another question was, did you know, or were you able to gather what the incidence of hernias is in living donors? Is that data even, do you know if there's any data out there on that? I mean, assuming that would be a never event, someone commented.
Yeah, but it's not an every event. So I'm happy to see that we have more robotic surgery on those kidney donations, because we can avoid a bigger trauma for the ab wall. But it happens. I don't think they are included on this cohort. This is only for patients that get receive the graft, not for donors. But maybe interesting. I don't know if QC has any. Maybe Ben can or Mike can chip in, but I don't think you have any way to input that is a donor, or we do. I don't know if we have in the database.
Yeah,
the way.
you can.
You can?
You can.
Okay.
Flavio, it's interesting. I mean, the follow-ups on these patients are less than 50%, like, because the transplants, like, patients are like basically married to the physicians and transplant surgeons, and almost they have a constant follow-up. I would expect that to be more. I wonder why it's less than 50%.
Yes, again, they are being followed up by the transplant service, not by the ab wall hernia surgeon that is inputting QC. And usually, even here, it's not their surgeons, the transplant surgeon that follow up a long term, are the medicine team, transplant team that follow up those patients. Maybe they are not aware that they should put data on QC. I think that's the only explanation that comes to my mind.
That's great. Well, thank you so much. And we're going to end with our last talk, Dr. Horne out of Penn State Health in Hershey, Pennsylvania, outcomes of Botox in abdominal wall reconstruction.
Awesome. All right, I'll just share my slides. Awesome. So thank you so much for inviting me to participate in this session of the ACHQC Core Insights. And I'll be talking about our work that I did when I was a fellow at the clinic about understanding the benefits of Botox in abdominal core health, based on the Abdominal Core Health Quality Collaborative. The only disclosure that I have is that I lecture for Medtronic, but it is not relevant. And so not all hernias are created equally. Certainly there are some that are significantly more challenging than others. And when we evaluate these hernias, they're often associated with what we call loss of domain, where the majority of the intra-abdominal contents are outside the abdominal cavity now. And when we see one of these patients in clinic or, evaluating their CT scans, we pull out all the stops in order to provide the patient with an optimal hernia repair. And so there are quite a few things that we can do in order to obtain fascial closure in these patients. And those include a chemical component separation. Sometimes progressive pneumoperitoneum is used. Myofascial releases are commonly used. And additionally, these can all be used together, a couple of components together. But in general, the goal is to achieve fascial closure in these patients. And so the use of a chemical component separation has become increasingly popular recently. And I think that's because we do have some objective evidence that there is some changes to the abdominal wall musculature. As you can see here, there's these two studies by Ibahara Hurtado as well as Farouk out of New Zealand that showed that When Botox is administered preoperatively, you do see increasing length in the abdominal wall musculature. And additionally, sometimes there is a decrease in the overall hernia volume. And so because of that, we see it being utilized more frequently. There are, however, some limitations to understanding its benefits. And as I had mentioned previously, a lot of times this is used as an adjunct to other procedures, whether it's progressive pneumoperitoneum or myofascial release. And this study was recently published by Dierenberg et al. And they showed that while Botox actually increased fascial closure rates, and this was significant, they also showed that there were more patients that had a component separation in this group. So it's really hard to tell whether or not it was the component separation or the Botox that really helped obtain fascial closure. And so what do we actually know about chemical component separations currently? Certainly it's associated with minimal morbidity. There's not a lot of complications associated with it. And we do know that there are some changes to the abdominal wall musculature, but how that translates to a clinical benefit is yet to be determined. We also don't know that the optimal dosing regimen. There's multiple different regimens with up to 200 to 500 units being administered in multiple different sites. So there's still a lot that we need to figure out in terms of how to use this appropriately. I think another big limitation to its understanding is we really don't have a good measure of loss of domain. This picture on the right is by Tanaka, and they calculated a volumetric size of their hernias when compared to the abdominal wall volume, and used this to determine whether or not patients should get preoperative pneumoperitoneum. That being said, we don't know if a certain volume size is associated with fascial closure rates or not. It was just large. Additionally, when preoperative chemical component separation is used, it often is simultaneously used with progressive pneumoperitoneum or component separation. And so it's really unclear when we kind of evaluate these very complex hernias with loss of domain if we were able to achieve primary fascial closure on their own and how much each of these adjuncts are playing a role. So that was the aim of our study. We wanted to determine whether or not preoperative chemical component separation increased primary fascial closure rates. In order to do that, we looked at the ACHQC, and we chose hernias greater than 15 centimeters in width, as this was a surrogate for complexity, as well as, it's unlikely that these hernias would be able to be closed primarily. We identified 8,451 patients and then propensity matched these at a 3:1 ratio to those that did not or did receive a preoperative chemical component separation. And we chose to control for things that might affect a primary fascial closure rate, including ASI, BMI, age, recurrent hernia repair, history of an open abdomen, CDC wound class, and presence of a stoma. And in total, we identified 97 patients that underwent a preoperative chemical component separation to 291 that did not. Our primary outcomes of interest were fascial closure rate was the primary one, and secondary outcomes of interest were wound events, morbidity, early recurrence rates, and quality of life. And so the baseline characteristics, most patients had an ASA 2 or 3. The average BMI of our patients was 32 to 33. The average hernia width was about 15 centimeters, and hernia length was about 20 to 21 centimeters. Greater than 50% in both groups had recurrent hernia. Stomas were present in 10%, and 30% of the patients had a history of an open abdomen. And after our propensity score matching, none of these were significant. When we look at operative approach, it's not surprising that 100% of these were approached from an open approach, which really kind of is just a surrogate for complexity. Additionally, greater than our 80% and up to 90% in the preoperative chemical component separation required greater than 2 hours to perform the operation. Mesh was utilized in greater than 90% of both groups, and the overall mesh width was the same. Mesh length was a little bit longer in the non-chemical component separation group, but this was not significant. However, when we look at mesh type, there was a difference with more biologic mesh used in the preoperative chemical component separation compared to a permanent synthetic. And this might be driven by the fact that we noticed that there was a more frequently mesh placed in the retrorectus space in the non-chemical component separation group versus the preperitoneal and intraperitoneal position. When we look at myofascial release rates, so more than or approximately 3/4 of the patients had a myofascial release. But the type of myofascial release differed between the two groups, with more patients getting an external oblique release in the preoperative chemical component separation compared to a retrorectus surgeons versus subdominus release in the non-preoperative chemical component separation group. When we look at fascial closure rates, it occurred in about 85 to 86% of the time, and this wasn't significant. When we look at the group that didn't get a myofascial release, so our question was, if patients got Botox and they didn't have a myofascial release, was there going to be an increased rate in primary fascial closure? And there actually wasn't, and it was 22% in both groups. And so when we look at 30-day outcomes, there was no difference in readmission, reoperation, or early recurrence. In any of the groups, there was no difference in wound morbidity between the two groups, and the only statistically significant difference was the fact that there was a higher DVT rate in the preoperative chemical component separation. We also evaluated patients for their quality of life and used the NIA PROMIS 3A scores to evaluate pain. There was no difference in baseline pain scores between the two groups. At 30 days, you would kind of think the Botox people had a slightly lower pain score, but this was not the case. We actually saw the preoperative chemicals component separation, or no preoperative chemical component separation, had a slightly lower pain score, but there was no difference at 1 year. And when we look at quality of life scores measured by the Hercules score, the only significant difference was that there was an improved quality of life in the non-preoperative chemical component separation at 1 year. And so what conclusions can we draw from this data? First off, their use of a chemical component separation did not help with fascial closure rates. And so the other thing that we noticed was that there was not a decreased need for component separation. When we evaluated the patient's patient-reported outcomes, there was really no improvement in pain if preoperative chemical component separation was used, and actually patients that didn't get one had a little bit better pain at 30 days and improved quality of life at 1 year. But I will take a minute to just kind of discuss some of the limitations. I think the one thing that we noticed that there was a significant bias in determining loss of domain. And so while we chose 15 centimeters as a surrogate for potential fascial closure rates, how people approach these hernias is different. We saw in terms of what type of mesh is used, where mesh is placed. And so whether or not these are kind of affecting who should get Botox, there's probably a lot of surgeon bias in determining if this person needs Botox, this person needs a component separation. I think additionally, when you kind of evaluate a complex hernia, they need Botox, they need a component separation, and then there's no pause when you are in the OR saying, hey, does this person really need a component separation? And so I think that also kind of confounds some of the data. When we kind of look at the patient-reported outcomes, our numbers were very, very low. Our sample size is very low. So I think it's really difficult to draw any conclusions from the results that we saw here. And so the question is this the end of Botox? And I would say the answer to that is no. I do think we really need to identify a patient population where fascial closure rate is routinely challenging. And I think the hardest thing to understand is this could vary significantly between different surgeons. And then once we take a group of patients where we know that we have a hard time achieving fascial closure rates, even with a component separation, evaluate the use of Botox in these patients. And then, we often say that this is good for a chemical or for fascial closure rates, but is there other benefits of Botox that we don't realize? For example, when we close really big hernias and have very, very tight fascial closures, there's certainly a higher risk of respiratory complications in those patients. And so maybe it doesn't help with fascial closure rates, but can minimize morbidity in other situations. So I think there's still a lot of work we need to do to kind of further delineate the benefits of a preoperative chemical component separation. Thank you so much.
Great, thank you, Charlotte. Why do you think there was a difference in the type of component separation done between the two groups?
The type was mostly based on surgeon preference. So there was a significant amount of surgeons that did one type versus the ones that did another. So it's truly just like a surgeon approach to those hernias.
Great talk, Charlotte. I have one question. I mean, I can see that how Botox can help in trying to relax the muscle, able to assist in closure. But I wonder that muscle will be paralyzed for 6 months, whether it is any disuse, atrophy, or have any long-term outcomes about that?
We don't have any data about that. And I think a lot of times when there is studies that present information about this, it's mostly the patients get the Botox and then are operated on at about 4 weeks. And so there really is not any mention of atrophy, just that, you know, they've got the fascia closed, and that's great.
Rich Pierce had a question that he commented, although he doesn't use Botox often, he always does a component separation. Do you or does anyone on this session use Botox but not do a component separation? Is that something you would consider, or anyone would consider? I would say no. I would agree with Rich.
I mean, I have to tell you, I mean, I did a few cases with Flavio. We Botoxed, and most of the times we end up doing like when these large complex hernias are mushroom shaped, so the flaps are already raised, we could easily close the belly without component separation and just do an onlay at that time without component separation, because when there's no tension at all.
Any other thoughts or questions from the group? I know we're running a bit over. Thanks, Charlotte. That was really great. Very, very good hot topic there. So thanks for joining us. And thanks everyone for joining us for today's QC Core Insights. If you have any other questions, feel free to reach out to the speakers or to us, and hope everyone has a good night.
Thank you.
Thanks, everybody.
Thank you.
Great job.
Thanks, everybody. Have a good night. Great.
Night.
Thanks. It was awesome.